Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to have an episode about the pediatric presentation of toxic emergency. As a pediatric emergency provider, one of the things I always think about when I see a child with altered mental status or some abnormal neurological findings, especially if it's a toddler or maybe a teenager, I think about some kind of toxic ingestion. I therefore decided to have a guest come on the show who's a toxicologist and can tell us more about toxic ingestion, toxic emergencies, and how we can handle them best in the pediatric emergency medicine. And to my surprise, I found an old friend and an old colleague and a mentor from my fellowship who happens to now be a pediatric toxicologist. He wasn't when I met him. So I decided to invite Dr. Brian Schultz to come on the show and talk about pediatric toxic emergencies. So thank you very, very much, Brian, for coming on the show. I know what you do for a living, so I know you're very busy. I appreciate your time. Let me just introduce you to the PEM Rules listeners. And please correct me, Brian, if I'm wrong at any point. You are originally from Pittsburgh, Pennsylvania. You went to medical school in Johns Hopkins, then went back to Pittsburgh, did your residency and chief residency at the Children's Hospital of Pittsburgh. After that, you went to Texas Children's for your PEM fellowship. So clearly you got great training, went back to Pittsburgh and served as faculty for the PEM fellowship. Brian was my faculty when I was there. Somewhere after that, Brian moved to Florida and was a PEM attending at Fort Myers. And at some point, to my surprise, in 2020, Brian decided to become a toxicologist. So he moved to DC for a 2-year toxicology fellowship at the National Capital Poison Center, finishing in 2022. And then currently, Brian, please correct me if I'm wrong, you're a PEM attending at Johns Hopkins. Is that right?
Correct.
Yeah. And a toxicologist, obviously?
Yep. Yeah.
Right? On a personal level, I can say that Brian was one of my favorite attending to work with. All the fellows at Children's knew that when you work with Brian, you're going to learn a ton, mostly non-PEM related stuff, like where's the best alcohol in town and where the prettiest girls hang out. Nonetheless, it was a great learning experience and we loved working with Brian. Brian, welcome to the show. How are you?
Yeah, good. Thanks for having me on. That description was many years ago. I was a younger man and was doing research as to be a future toxicologist. I think that was just all training to be.
Sure. Very good. I'm glad to hear that. Brian, my first question to you, and if you listen to the show before, you know that's the question I ask all my guests, and everybody has their own answer and their own approach and perspective. What is your definition of a good PEM physician? One who does what?
I think it's one who is very curious about their patients, that always strives for something to learn from each patient encounter, drills down in the history, is very precise, is very specific, tries to extract as much information as they can, tries to do the best for their patients, one who is empathetic, and one who enjoys teaching a wide variety of learners, from students to all kinds of different residents, whether family practice, pediatrics, emergency medicine. I think that's what ultimately makes a great PEM attending.
Very good. I agree with all the above, especially the teaching. I also have a big passion for that, as you know. Mm-hmm. And I definitely agree. My next question to you, Brian, is again, and obviously that specifically to you as a toxicologist. In an attempt to keep things simple, I try to think of pediatric emergency medicine and teach pediatric emergency medicine as a simple field. That's how I think about it. When I see a sick child in front of me, whatever sick kid means for me, I always think about what will kill the child now, and I can fix it. So anything that poses a risk to the child and I can fix it, I check for it right now. So, a classic example, we all have low threshold to check the glucose because hypoglycemia can kill a child and we can fix it. I can't fix a head bleed. I have to call someone, so I'm not going to send the child to head CT before I check the sugar. From a tox standpoint, the classic teaching that I got from Pittsburgh and my experience is with toxic ingestions, there are really two things that pose immediate harm to the child, and that is hypoglycemia and or arrhythmia. So checking glucose and checking EKG are super important for me in when I think about this possibility of toxic ingestion. Do you agree with that statement? Would you add anything? What do you think?
No, I think that's a great way to look at it. I mean, I think checking an EKG, I mean, certainly a lot of your dysrhythmias might be evident upon arrival when the patient evaluating the patient's clinical status and looking at the monitor. But I would definitely say that in the poison patient, getting a point of care dextrose stick and an EKG are two of the most important tests you can get, probably way more important than the quote unquote tox screen. Certainly getting, you can see hypoglycemia in lots of ingestions, oral different hypoglycemic agents like sulfonylureas, glipizide, things like that can certainly cause very profound recalcitrant hypoglycemia. Ethanol ingestion can cause hypoglycemia. Salicylates can cause hypoglycemia. And then certainly, dysrhythmias. There are lots of things out there that can cause dysrhythmias. The list is super long, but lots of things that are commonly prescribed out there. Bupropion is a big one that's often, sadly, commonly ingested amongst adolescents and self-harm attempts. And so absolutely, I would echo that statement, and that a dextrose stick and EKG is one of the most important tests to get, or two of the most important tests to get.
All right, very good. I'm glad I learned well and doing the right thing for my patients. Brian, the next question, and this is a true story. I was just in that position not too long ago. I've had situation, again, this is a very specific situation just happened. The patient presented with those non-specific symptoms with fairly acute onset, and I was convinced the kid got into something and it was a toxic ingestion. It actually ended up being a very acute, odd, fast onset encephalitis. And I was really surprised. And I wanted to know, do you have any tips for us, PEM physicians or clinicians, to tease out those kids with toxic ingestion versus anything else?
Well, that sounds like a tricky case, because you're right. Encephalitis tends to be, I haven't seen a ton of cases, but I have seen a handful. It doesn't tend to be that fast. Typically when you see this kind of rapid change in mental status without an immediately obvious explanation, of course, like a trauma or anything like that, certainly ingestion always comes to the top of my mind. Certainly, they just got back from grandmother's house and now they're acting altered. They just got back from grandfather's house and now they're acting agitated. Certainly family members can certainly have pills in their houses that they don't always lock up. And so, that kind of rapid onset of altered mental status, whether it be agitation or on the other end of the altered mental status spectrum, extreme somnolence certainly can be a clue. Certainly when they get back from somebody else's house, or they're being watched by a babysitter, or they're being watched by somebody else, that always raises the antenna for me that it could be an ingestion. Certainly those age ranges as well. We see kids of all ages as a toxicologist in a pediatric setting, but certainly to the two big age ranges that we see tend to be the younger kids, toddlers, the so-called unsupervised exploratory ingestion that are exploring their environment, and they get into things, whether it be pharmaceuticals or illicitly prepared substances. I've seen tons of kids over the last X number of years who have gotten into illicitly manufactured fentanyl products in their environment. Or a huge issue, and I'm sure you see that too in Vegas, is people getting into oral gummies of not just gummies, I guess I should say, all edible preparations of cannabinoids. And then the other, on the bimodal distribution, we certainly see are teenagers, and they get into things not just for self-harm attempts that I alluded to earlier when I mentioned bupropion, but also for recreational drug use as well. So you look at the whole picture. I think it can be very complex, and the story or the case you shared, I think, was probably a very tough one, because we kind of look at the time course of things like that, and then other signs and symptoms, fever, possible exposures, to try to differentiate the two. But sometimes, it's not always clear, and they end up getting a big workup. Oftentimes kids who are altered end up getting MRIs and EEGs and even lumbar punctures, and then the next day the comprehensive drug screen comes back positive, or the child wakes up and admits to it if they're an older kid, or a medicine is found missing in the home. I took care of a couple kids in fellowship that had that exact thing happen. They got an LP under sedation, MRI, and all this stuff, and then woke up and admitted to taking diphenhydramine or things of that nature. So, like anything, like you mentioned too earlier, what makes a great PEM position, being diligent, drilling down in the history, being precise in your terminology and questions you ask, and how you communicate with your colleagues and your subspecialty consultants and stuff like that. I think that's why I enjoy that field so much, because it's so challenging and requires so much thought.
Very good. That's really great information for the PEM rules listeners. And what I hear from you, and I think that's why that case kind of tripped me, is the acute onset of those odd symptoms really should make us feel maybe this is tox related. Anything on the physical exam that should point us in the direction of tox?
Yeah, I think there are different things we look at in the physical exam in the tox world, right? I mean, we certainly look at the vital signs, the laundry list of ingestions or exposures, I should say, not just ingestions that cause tachycardia is, super long, but, the list that causes bradycardia is a little bit smaller. So you can look what's the most kind of, salient aspect of the presentation. So you can of course, look at vital signs, hypotension, hypertension, bradycardia, tachycardia, hypothermia, can be seen in clonidine ingestions and things like that. And hypothermia can go along with hypoglycemia sometimes. So you look at your vital signs. Mental status, are they depressed? Mental status, are they so-called cold and sleepy toxidromes, like you might get with a sedative hypnotic, like a benzodiazepine or an opioid, or clonidine, like an alpha-2 agonist, or they very agitated, the so-called hot and crazy syndromes, a sympathomimetic or serotonin syndrome, or withdrawal from another, if they're, if they have opioid use disorder or benzodiazepine use disorder or something like that. So certainly looking at the mental status. Also, I think that what we look at a lot that might be unique, some of the things I'm mentioning, all great PEM docs look at, but I think that we pay particular attention to the pupils. Of course, some miosis that can be seen in opioids, and also, clonidine alpha-2 agonist ingestion, and then mydriasis, like you might see with the cholinergic, more specifically antimuscarinic ingestion like diphenhydramine. Look at the skin, the so-called toxicologic handshake, where you put a gloved hand underneath their axilla. You might see, a sympathomimetic patient might be really, really sweaty unless they're, been out in the sun for a long time in Las Vegas and dehydrated, or, the really antimuscarinic poison patient might be really dry. We'll look at things like bowel sounds, although we say that a lot in lectures and environments like this, but in reality, that sometimes is very difficult to ascertain. Urinary retention, if you're skilled with POCUS, which I am not, you could look and see if they have urinary retention. That can be a clue if the patient has antimuscarinic poisoning. And then I think in today's day and age, I think, we see so much serotonin toxicity. We talk about these so-called hot and crazy syndromes, but a lot of those things we don't really see much. We never see malignant hyperthermia. We very rarely, see some of these, in the pediatric age, we don't really see withdrawal very much at all. But we do see lots of serotonin toxicity, and most of those kids do very well. To die of serotonin toxicity in today's day and age is extremely rare, but I think a clue to that is clonus. I think that one of the first things I'll do, when I see a patient being brought into the room, it's a little bit agitated while the nurses are working on getting the monitors set up, and I see that the child isn't acutely decompensating, I will go right to the ankles and start jerking on the ankles to see if they have clonus. So those are, I think, some of the unique things that we look at: clonus, pupils, the skin exam, that can give us clues as to where some patient might fit on some toxidrome hierarchy.
Excellent. So, wow, perfect. Those are, again, great advice and great pros for us PEM clinicians. Two more questions to you, Brian. The first one is, to what, I have a hard time kind of phrasing it, but to what degree do you agree with the following statements? Toxic ingestions don't cause fever. Again, trying to differentiate infectious versus toxicologist. or
Well, I think
toxicology? Sorry.
that statement, the terminology there, the specific word definitions are important. I would
Okay.
say they don't cause fever. I think they can cause hyperthermia, which is a different thing. You know, fever being a beneficial response by the body in response to an infection to help your immune system work better and to slow down the growth of viruses and bacteria. But many toxic ingestions can cause hyperthermia for various reasons, like an uncoupler like salicylates that uncouples oxidative phosphorylation. Your electron transport chain is just running, but that energy is not able to be harnessed into creating ATP, so it creates heat. So a very severely salicylate poison patient might be hyperthermic, not fever, and you wouldn't give that patient acetaminophen, but the temperature may be hot. Now, serotonin toxicity, what I mentioned before, can cause hyperthermia. It rarely does. If somebody is on one of the old monoamine oxidase inhibitors like phenelzine or something like that, that patient who's given meperidine and then maybe or maybe not had done cocaine, as a famous case, as happened in a famous case, that patient could die of serotonin toxicity. Severe anticholinergic, or we should say antimuscarinic toxicity, rarely results in life-threatening hyperthermia. But certainly, an extraordinarily agitated patient who is on methamphetamine or who is on PCP, who is extraordinarily agitated and is being physically restrained, instead of being given, copious, incredible amounts of benzodiazepines to sedate them, and is being restrained by physical restraints and multiple security guards, that patient could become very hyperthermic. So I would agree with the statement that toxic ingestions don't cause fever, because fever is the beneficial response, but toxic ingestions can absolutely cause hyperthermia.
Very good. So I guess the more you speak, the more I'm fascinated, and the more questions I have. What I'm hearing you saying is, if I figured out this is a toxic ingestion and the kid's temperature is elevated, hypothermia, acetaminophen is not the avenue.
Yeah.
External cooling.
I mean, if they are very hot, that's what's going to kill them. If there are many ways you can die from different ingestions, but in reality, what's the most life-threatening thing, if that patient comes in and they are extremely agitated and they are 41 degrees centigrade or even hotter, they need to be cooled immediately, and which makes it a challenge, right? How are you going to cool quickly this extremely agitated, usually older, adolescent or adult patient? And there are places that do it very well. Patients, places that deal with a lot of environmental emergencies, heat stroke, as probably occurs in Nevada where you are, you need to dunk that patient. And how are you going to do that? And in reality, you're going to have to chemically sedate that person. So probably what's going to happen there, you have identified life-threatening hyperthermia in a poisoned patient, intoxicated patient. You need to sedate them aggressively and very quickly, which is going to probably be extraordinarily high doses of benzodiazepines. And then, you're probably going to have to paralyze them and intubate them and put them on propofol, something that has tremendous GABA agonism, is what that brain needs at the time, probably even some NMDA and NMDA antagonism, and then you can cool them. And people have done that different ways. I think, getting a core body temperature, this is the case where you're going to need a rectal temperature, and then you're going to need to dunk them in water. I think not every place can do that. What I've seen other places do is they have body bags and they can pack it around, put the patient in the body bag and just pack ice around it. You need get that patient down. And you need to get that to cool them quickly. That's what's going to kill them.
Wow.
So I've not had to do that in full disclosure. I did it once in Florida for a patient with heat stroke, that ultimately died. We had ice all around him, but by the time he got to us, it had been 45 minutes since he collapsed on the field. But I have not had to do that for a poisoned patient personally yet. But it's something you need to know how to do. And I think that, we get caught up on these other vital sign abnormalities, which is absolutely important. We see so much fever in peds world. We usually don't worry about it, but these hyperthermic poison patients, it's extraordinarily scary.
Sure. Yeah, no, that's an impressive story, I got to say. One last question, or not really a question, but when you and I discussed weeks ago the script or the topic, specific things we want to say for this conversation, you mentioned it would be a good opportunity to talk about the importance of poisoning prevention and the role of regional poison control centers. I always teach my residents at least 50% of what I do is anticipatory guidance and attempting in preventing injuries, not treating injuries. The
Yeah.
stage is yours, Brian. What would you like our listeners to hear about poisoning prevention and poison centers?
Oh, my current division chief, Tish Ryan, would be very proud right now because she's a big injury prevention advocate and expert. But I think that yes, the poison centers are there. They are a wonderful resource. I work with the Maryland Poison Center right now. I take call from them once a week. They are continue to be blown away by their knowledge, their dedication. It's a tremendous repository of data, of advice. And so, utilize your poison centers if you don't have a medical toxicologist at your institution, which, most hospitals do not. But everybody has access to the poison center, 1-800-222-1222. So anybody can get in touch with them. I think that, it would be, redundant for me to sit here on this podcast and talk about, blocking up your medicines. And I think everybody knows that. I think, what we talked about before, I think a little bit off before we got on the air was this, almost epidemic of cannabinoid edible ingestions that we're seeing right now, because the packages are just absolutely insane how much they look like regular candy, whether it be gummies or THC nerd rope, and kids find them. They have a way of getting a hold of them. Get candy. Jerry Seinfeld talks about in one famous comedy bit he did. He talks about how when he was a kid, what his attitude towards candy was. He would try to get candy at all costs. And I think kids do that, and they find them, and then they end up in the ED, and they usually do fine. But I've had some bad ones. I've had some, many kids were intubated for extraordinarily altered mental status or very altered mental status, and even some kids on pressors and stuff like that. So I think that what we can advocate when we see these patients is, having parents lock up anything they're doing. These THC edibles might be very fun to do, and might certainly maybe help somebody with certain medical issues. And it's not a point to judge or make a statement about the legality of these products for or against. But if they're going to use them, just make sure they're locked and hidden. What I would say is not just locked and not just hidden, but locked and hidden, because otherwise kids find a way to get into things.
Very good. No, that's and again, that's great advice. I think we often don't think of these topics as really PEM specific topics, but again, I think at least 50% of what I do is general pediatrics, and I truly enjoy it. I teach that to the residents and the fellows now. Brian, thank you very, very much for coming on the show. This was incredibly helpful and educational. And as I am sure you know by now, there's a custom on PEM rules. Every guest get to choose the outro I will be playing in their honor. And I guess you wanted to hear something by the band Poison, not surprised.
Yes. Yeah.
And a song called Fallen Angel.
Yeah, I think it's one of my favorites. There's so many good Poison songs. It was difficult to choose. I grew up in the 80s. I was a kid in the 80s. I had a mullet, and I listened to Poison, Skid Row, all those bands. And so I had to come. I always wanted to I would love to organize a fundraiser for the Poison Center and have Poison be the cover band at the end. I think it would be a killer and would probably be more successful than Lollapalooza, in my opinion.
That's hilarious. That's a good goal. That's a good goal.
Yes, my goals.
I was born. I was a teenager in the 90s, so for me it will be Nirvana. But whatever works.
Yeah,
I don't think Nirvana will make for a very good Poison event of any sorts. But
not anymore.
Not anymore. Brian, thanks again. Great talking to you, and again, really great teaching. Thanks so much.
Yeah, thanks, Ron.
And that is it for today, guys. Thank you very much for tuning into PEM Rules and listening to Brian and his wisdom. Of course, Brian, I'm using the term wisdom very loosely, but thank you. Anyhow, Unfortunately, Brian, Poison by Fallen Angel was a no-go. That song is way above my grade. However, I hope you like this outro. This is Poison by Alice Cooper, 80s just like you wanted it. Thanks again for listening, and don't forget to subscribe to my newsletter as well as check out the new Facebook page. Not a whole lot there, but hopefully some more stuff in the future. Have a great day. Thank you very much.